Hi everyone, welcome to researchmd.com. We have a great presentation. Today we're going to teach you everything about febrile neutropenia. Okay. Again, my name is Pramil. I'm a program director in internal medicine residency, transitional residency. I teach medical students and residents on a regular basis. So let's get into our topic. When you talk about what is febrile neutropenia, fever, okay, single fever, it'd be a single fever, right, 101 degrees or 38.3 degrees centigrade, or sustained elevated temperature 100.4 degrees in a patient with ANC or absolute neutrophil count less than 500 cells. Now, how do you calculate the absolute neutrophil count? You take the percent of neutrophils plus percent of bands and you multiply by WBC and divide it by 100. Okay, that's what you have. So the number to remember is like ANC, less than 500, fevers, single fever 101, elevated temperature 100.4 degree persistent, and all those kind of things. Define it. Epidemiology: 10 to 50% of the patient with the solid tumor malignancies, or 80% of the patient with hematological malignancies. So very high risk, right? So low ANC count typically results from cancer therapy, and the source of fever could be infection. Either it could be bacterial, viral, fungal, and all of those kind of things. It could be gram positive. If it is gram positive, coagulating negative staph, and MRSA, viridian, streptococcus pneumonia. Gram negative, E. coli, Klebsiella, Enterobacter, and Pseudomonas, and all that's kind of common. Signs and symptoms: you look for, patient can present with a fever, abdominal pain, mucositis, some perirectal pain. Some of the conditions, because they're so immunocompromised, they might not have some of the symptoms. Okay, so diagnosis: make sure you do the routine things. You have to check CBC, make sure blood cultures, and always when you do examine, look for the port, either a CV, there's a central venous catheter or any other port for chemotherapy that need to be drawn, and you need to be cultured from that site. Okay, BMB, creatinine, blood glucose, LFT, serum lactate, all of this to be checked out. And the labs, make sure, we talk about urine analysis and the urine culture, stool culture, wound culture, respiratory viral panel, ESR, CRP, and procalcitonin. All of those are very useful. Now, some situations like, extreme measures like bronchoalveolar laryngitis, unknown infiltrate on chest imaging, and then if you're suspecting meningitis, of course you have to do CSF analysis. So what are the markers you have to, fungal infections also, you can think about galactomannan testing, and 1,3-beta glucanase is also kind of useful in the fungal to make sure. The first thing I would do is go for this, anything you have to risk assessment model is very, very important, right? You find there's a mask risk assessment for the patient risk stratification. Anything you do, always risk stratify. So you go through online, get a mask score on this patient, and what are the things in the clinical burden of symptoms, absence of hypotension, absence of COPD, solid tumor, absence of severe dehydration, patient status when fever occurred, and then you have some scoring is given on the right side. So how do you interpret it? If the mass score is 21, high risk for serious medical complication or death. Okay, very high. So make sure you calculate the mass score. It's very important. And then all patients, start neutropenia precaution, risk stratification, establish IV, start empiric antibiotic therapy, consult oncology, ID specialists, provide supportive care and all that. High risk patient, consider ICU, give them broad spectrum antibiotic, narrow the antibiotic. Once we have the results, consider need for empiric fungal therapy for neutropenic fevers. If the fever persists more than 4-7 days, reassess for the fungal or viral infection. And low risk patients, some of them based on the mass score, you can do oral antibiotic, and close monitoring should be done. Antibiotic high risk patient, what is the current recommendation? You start monotherapy with the IV, anti-pseudomonal beta-lactam agent is recommended, like cefepime or ceftazidime, 2 gram IV every 8 hours. Then you got IV Zosyn, you can do every 6 to 8 hours, and or other anti-pseudomonal carbapenem, imipenem, silastin, and meropenem. You can use the dosages given. Okay, and the vancomycin. When do we give vancomycin? They not usually recommend the initial stages, but any of the following suspected categories you can use vancomycin. Okay, what are they? Suspected catheter-related infection, skin or soft tissue infection, pneumonia, hemodynamic instability, known colonization or high-risk colonization, if the patient has colonization with MRSA. So those conditions you can vancomycin. Now, when do you give antifungal? Let's say you got like persistent fever out to 4 to 7 days of broad spectrum antibiotic therapy, and you cannot identify the sources. You should start looking for fungal infections, start treating the positive fungal markers we already talked about, and all of this can be done. And if they're high risk also, especially high mass score, you can start antifungal therapy. So low risk patient, again, you can do oral or IV antibiotic. Oral therapy, which one will be fluoroquinolone plus amoxicillin clavulanate, and or fluoroquinolone plus clindamycin if they have penicillin allergy. And don't use empiric fungal therapy if it is like a low risk, okay? Hospital stay required. If they're persistent fever and they get worse, that's why you have to close monitor the people at home at low risk and give oral antibiotic. But if the symptoms get worse or persistent fever, make sure you transfer the patient to the hospital. So prophylaxis, again, you want to increase the count. So what do you do? GCF, granulocyte colony stimulating factors. Like what are we have? Filgrastim and lenograstim. Just remember those names. Granulocyte colony stimulating factor drugs, okay? These are the references. Thank you so much for watching. We'll be back with another presentation soon. Please subscribe to our channel.